when it comes to how healthcare professionals experience the healthcare system in the state with health insurance, with 1 and 2 being enrolled in one of our programs. And then 1 and 2 births are covered by already by Medicaid. And so when you add in all the other employees, that we do have a huge impact on maternal health in the state and should be able to move that dial if we really get our solutions aligned. And then also, we have a huge impact on the budget. And so we spend on these services and payments to providers for the care that they provide about $13 billion. And that is state and federal dollars, just to be clear. So it's not all state dollars. Next slide, please. So just a quick update on our executive leadership team. As you can see, we have a full team. I'm very excited and proud of this team. I would just point out that the top row here is the director's office. So many of you know Melinda. She does all of our great workshops and public activity and stakeholder engagement. Sandy is over IT. Allie Jinko Herzik just joined our team. She is our chief of staff. And then Lynette Aaron, some of you know her from our budget side, and now she is over the department's budget. We also have Cynthia Leach, who recently moved into the role of administrator at purchasing compliance. This is also where our all of our regulatory work lies, as well as our facility licensure and our Medicaid Inspector General office that is working really hard to prevent fraud, waste, and abuse. We also have Jennifer Krupp here, who is our Administrator of Consumer Health, which is where our public option, Nevada Health Link, and our market stabilization waiver and reinsurance program, and all the work there that we're doing with CMS to ensure compliance with that waiver. And then Ann Jensen is our administrator over the Nevada Medicaid program. She oversees benefits and delivery system, all of our federal policy and waivers, community supports, long-term care. I would just note that before, this division also had the Medicaid Inspector General work. We moved it over, including provider enrollment. We moved that as well under Cynthia, so it's separate from the program, so it can be independent in its work, especially around fraud, waste, and abuse. And then we also moved the budget into the director's office, just given the size of the budget and the amount of work and the impact it has on the whole department. Teresa Carson is our executive officer over at Public Employees Benefits Program, and that is our what we also call PEB, which serves 75,000 employees in this state. Next slide. This is our leadership team that sits under the divisions. I wanted everyone to kind of see who fits under these buckets in case you need to know who to reach out to. As you can see, we have a couple open positions. We have a deputy administrator open at our Medicaid Inspector General office because Cynthia moved up recently. We also have Administrative Services Officer 4 open for purchasing and contracting, which we're going to be doing a lot of that with a lot of our large healthcare contracts. And then also we have a quality officer position open at PEV. So if anyone's interested, please apply. Next slide. All right, so we've been starting to outline a strategic plan or roadmap. And we just met earlier this week with the senior leadership team, start to kick that off. And so what you have here is just the strategic goals that we already talked about, and then each of the priorities under these goals and our strategies. There are more objectives that we are laying out, like actual projects that we're working on that fit up within these goals and objectives. So more to come on this, but I just wanted to kind of let everyone know where we're landing. When we talk about health improvement, we're talking about the 3 big ones, at least from our perspective, that we see that Nevada struggles in, which is, we already mentioned, maternal health, behavioral health, chronic disease prevention and management, which runs a gamut, right? That's a lot of issues and a lot of needs there. And then just having one thing we really want to do is work on a population health management strategy. And there are a lot of folks, and there are a lot of these things here on this slide that will be talked about later in this presentation. So I don't want to spend too much time here and let others talk about the good work that they're doing on these items. Next slide. All right, Melinda, I'm going to hand it back over to you.
Thanks. And I will pass it off to Erica.
Thanks, Melinda. Good afternoon, everyone. My name is Erica McAllister, and I am the School Health Services Liaison for the Nevada Health Authority. So I help manage the School Health Services Medicaid program. Since our last update, we've been making a lot of progress, and I'm excited to share a few of those highlights with you today. First, I'm happy to announce that the Nevada Health Authority has officially executed a contract for a new statewide electronic health record and Medicaid billing system for our schools. at no cost to the participating school districts. And the new vendor is BH Works, which is developed by Medical Decision Logic, Inc. So we are currently in the early stages of implementing this system through a pilot with 4 local educational agencies or school districts. And beginning in the 2026-27 school year, so this summer, all school districts across the state will have the opportunity to opt in to use this new system. In addition to our pilot, our team has been focused on developing new tools and supports for schools statewide, including updating the Medicaid School Health Services Manual to make it more user-friendly and easier to navigate. And we'll be hosting a public workshop on these updates on February 11th. We are continuing to expand and improve our School Health Access Resource Center, which is our website, with guidance and input from our steering committee. We have been offering monthly technical assistance opportunities, including trainings and open office hours, to support schools at every stage of participation. And finally, our team has been collaborating with statewide partners such as the University of Nevada, Reno, and the Department of Education to promote best practices for meeting students' behavioral health needs. And with that, if you have any questions about the program, please don't hesitate to reach out to us at schoolhealthservices@nvha.nv.gov. And I'll also put that email in the chat. And with that, I'll pass it back to Melinda.
Great, thanks, Erica. All right, let's see, moving on. Okay, so I wanted to provide an update on the justice-involved population and care initiatives that we have going on at the Nevada Health Authority. So some of you may be familiar, the Consolidated Appropriations Act of 2023 required all states to support Medicaid reimbursement of a limited set of services for juvenile populations who are incarcerated up to 30 days before they're released. And then also in 2023, we had Assembly Bill 389, which passed, that requested that the Nevada Health Authority apply to the federal government for an 1115 waiver to support Medicaid reimbursement for a more expanded, robust set of services for both adults and juveniles who are incarcerated up to 90 days before they're released. So basically right now we're working on the requirements of the Consolidated Appropriations Act and ensuring that all youth have access to those services. And we are also anticipating federal government approval, hopefully within the next few months, of our submitted 1115 waiver for reentry, so that we can provide that Medicaid reimbursement up to that 90 days before individuals are released. And this is really to, enhance that bridge, back to the community and ensure that folks have the tools and the support that they need to be successful. And so part of that effort includes the Nevada Health Authority was awarded a grant through CMS to support implementation of the Consolidated Appropriations Act requirements. And part of the activities under that award include support for an electronic health records vendor for carceral facilities to be able to support, that medical health record information system and transfer of data between the carceral facility and the community provider as well. So ensuring that we have that interoperability is super important, especially as these folks transition back to the community. So we're working with a vendor right now to develop that grant or sub-grant process so that those carceral facilities can apply for those funds to be able to implement those types of electronic health record systems. And we anticipate that to begin in July of this year. So with that, I'm going to pass it off to Jamie.
Good afternoon, everyone. Um, I'm Jamie Evans. I'm the Chief of the Managed Care and Quality Assurance Unit, and I'm here to talk to you about statewide managed care. So let's walk through some of the key items that we're monitoring, as well as the early wins we're already seeing in the statewide managed care rollout. First, provider network adequacy in our rural and frontier areas. We know there's potential gaps as providers adjust to managed care contracting. We're actively monitoring network submissions, conducting targeted outreach to critical providers, and relying on continuity of care and out-of-network provisions that are in the contract when needed to protect member access. Next, member transition and understanding. Some confusion is expected as members navigate plan assignments, benefits, and new access pathways. To mitigate this, we're coordinating member education efforts, supporting MCO-led outreach, and working closely with call centers and community partners to resolve issues quickly. Operational readiness is another focus area. Early implementation always brings the risk of claims authorization or data exchange issues. We're addressing these through tight cross-functional coordination with the MCOs and our internal Medicaid business units, rapid triage of issues, and clear escalation pathways. Turning to some of the early wins and positive indicators. First, statewide go live was successful. The expansion launched across all service areas without systemic access disruptions. Second, MCO engagement has been strong. All 5 plans are actively participating in implementation check-ins, issue resolution, and continuous improvement efforts. Third, provider onboarding continues to build momentum. We're seeing steady progress in contracting and onboarding, including key specialty and community-based providers. Finally, governance and oversight structures are working as designed. Milestone tracking, reporting, and interdepartmental coordination are supporting informed decision-making and timely course correction. So all in all, we're on an excellent path for statewide managed care. And I'll pass it on over to Anne.
Good afternoon, all. Great to see so many attendees here. I'm Anne. I'm the Medicaid Director here in Nevada. Excited to share a few updates on our children's behavioral health transformation. This is something that I know we've provided updates on through a number of these quarterly stakeholder updates, and we encourage those that may be interested in learning more, diving deeper, to join our Children's Behavioral Health Working Group meeting. Our next meeting is on February 12th, so the second Thursday of the month at 4 p.m. So we welcome you to come, and all those resources are available on our website. But I did want to share a couple of highlights with this group. Firstly, we are continuing to progress on our transformation effort to improve the coverage of behavioral health benefits for kids and families across our state, and to improve the way that we reimburse for services that we already do cover. We may be one of the more popular states of CMS right now. I think we have 8 different state plan amendments that we are waiting on for approval with them for this project specifically. So we're continuing to work with them on a weekly basis to ensure that those are moving forward as quickly as possible. Once approved, we will communicate that with our community stakeholders as quickly as possible, as those effective dates will range all the way back to January of last year for some of our rate increases, up to 2027, depending on the service. That will align with a new delivery system that's coming to our state, which is a health plan that's designed specifically for kids in our foster care system and kids with complex behavioral health needs. This will really align with that overall settlement, Department of Justice settlement goal, which is really to reduce the institutionalization of kids in our state that require behavioral health services and help them get the support they need and their families need at home and in their communities. We've made a few updates to the implementation plan for this specialty health plan that we'll be talking through at our working group in February. This will be effective in summer of 2027, though, so that is nearing very soon. And so we look forward to continued feedback from our community partners as we move through the procurement and implementation process for this plan. Lastly, I want to call out, I know psychiatric residential treatment facilities are a core component of our settlement process and our compliance efforts, and a key area of focus for any of us that are involved in the behavioral health space. I want everyone here to know that this remains a high priority for us moving into 2026 as we ensure our policy and licensing regulations reflect our goals of high quality, safe care for kids across our full state, as well as kids that need to leave our state to access the care that they need, with the goal of ensuring accountability for providers and high quality care. So we look forward to continued updates on those efforts throughout these stakeholder meetings and through our legislative forums ahead as well. So with that, again, welcome you to join us on our February 12th working group meeting if you'd like to learn more about any of those areas, and you're welcome to reach out. I'll drop the link to our website in the chat here. And with that, I'll turn it over to my colleague, Kirsten.
Thanks, Anne. Yeah, so it's nice to see everyone. So in terms of our implementation updates for seniors, we have two programs that I just wanted to briefly touch upon today. So the first is PACE, Program for All-Inclusive Care for the Elderly. So our update this time around is that we have successfully contracted with a vendor, Health Management Associates. So a friendly reminder, they are going to be assisting us in really working on that the state plan amendment updates, as well as our Medicaid services manual, and really all things PACE to get us set up for a successful implementation. And then we are having this week, this Friday at 10, we are having a specific stakeholder engagement just for PACE. And so would love to have those that are interested attend that as well. And so just these are the topics that we're going to go over, is that regulatory framework, the state plan and policy considerations, applications and approval process, and any other operational considerations. Really, the goal of the meeting this Friday is to solicit feedback from interested parties for PACE. We certainly are no means the expert, and so would love to have feedback from individuals that have worked with PACE in other states, or are really just curious about the ways that we should set that up. And so would love to have you attend that meeting this Friday at 10. And then the second program is our behaviorally complex care program, the quality incentive. And so that will be a new component to that program that we already currently offer through our skilled nursing facilities, and really developing quality metrics for those participants in that program. So we are at the end hiring stage for that that individual that we got from last session. And then we're also in the process of drafting those metrics, working with our clinical staff to make sure that those metrics are consistent with quality metrics that we see in other programs. So we should be hosting a public workshop in the coming months to really walk through what those state plan and policy updates look like for this program, so we can solicit feedback from interested parties for that. And I do see a hand raised, but I think we might be taking questions at the end, Melinda. If
Yes.
I should hand it over. Okay,
Thanks,
perfect.
Kirsten.
So
Yeah, we'll do
will
it at the
be
end. Thanks.
I will be on this meeting and happy to answer the question at that time. And I'll give it to Dr. Benson for the next slide.
Good afternoon. My name is Dr. Keith Benson. I'm the Nevada State Dental Health Officer. First, an update on our 1115 oral health and diabetes demonstration waiver. Our billing systems at the state are live, with Gainwell Technologies serving fee-for-service and Liberty Dental Plans serving Urban, Clark, and Washoe County for participating federally qualified health centers and tribal health centers. We have shared reporting deadlines with all clinics, which include biannual A1C reports and dental-related quality of life surveys. We are hoping to demonstrate that the expanded dental benefits can reduce A1C lab results in participants, and that's due to the strong connection between diabetic control and dental treatment. I would also like to recognize Pyramid Lake Tribal Health Clinic, Walker River Tribal Health Clinic, and Nevada Health Centers for being the first clinics to submit claims to Nevada Medicaid for this program. Next, we have the adult dental coverage implementation. Research and policy development are ongoing with our third-party vendor, Manat, which is helping us look at how other states have implemented their adult dental coverage. State plan amendment and contract language is also in development. And we have been sharing some Nevada Medicaid utilization data to try to build the program as well. And we are on track for July 1st, 2026 effective date. I just wanted to mention to all the providers out there that the Treasurer's Office Nevada HEAL Loan Repayment Program is accepting applications for medical and dental providers providing care in rural and urban high-need areas. And with that, I'll be happy to answer any questions at the end. And I believe I'm handing it over to Administrator Jennifer Krupp's Consumer Health Team.
Thank you, Dr.
Good
Benson.
afternoon.
I was actually going to say I'm going to pass this off to Janelle Davis, our Executive Officer, the Silver State Health Insurance Exchange, and our Agency Manager, Adam Plain, over the Public Option Program.
Wonderful. Thank you, Jennifer, for that introduction. Good afternoon, everybody. We have concluded our open enrollment period for the health insurance marketplace known as Nevada HealthLink in the state of Nevada. Open enrollment kicked off on November 1st of 2025 and ended on January 15th of 2026. And that was for coverage that would start February 1st of this year if you enrolled through the enrollment deadline of January. If you enrolled by December 31st of 2025, your coverage start date would be January 1st. Just wanted to talk a little bit about the challenges that we had this year. While exchanges nationwide experienced some pretty high rate increases, Nevadans continued to enroll, which really demonstrated the value placed on having health insurance coverage. So you can see here that the average was about 26% on and off the exchange. That's an average weighted rate increase. Another big challenge that we experienced was the enhanced premium tax credits that expired at the end of 2025. This obviously impacted affordability. However, it's important to note that subsidies still remained available. So NevadaHealthLink.com is still the only place where Nevadans can receive financial assistance from the federal government known as subsidies to help offset those monthly premium costs for coverage. The expanded subsidies is what went away, so that would be above the 400% of the federal poverty level. And also, we really, some messaging that we leveraged was really to shop the marketplace, to visit NevadaHealthLink.com and see what your options are, because there were new options this year and still at an affordable price. So we really utilize that message to encourage Nevadans to visit the marketplace and to get free assistance from a broker or navigator throughout the state to help them enroll in coverage. And for the rest of this, I think I will pass it off to Adam Plain to talk about Battle-Born State Plans.
Thank you very much, Janelle. So this was the first year that Nevada implemented the Battle-Born State Plans and the public option. The Battle-Born State Plans are plans sold through NevadaHealthLink.com. This year, we set a premium reduction target of 7% for our 3 Battle-Born State Plan participant insurance companies. And all 3 of our Battle-Born State Plan carriers did hit that 7% premium reduction target, which resulted in an average consumer premium decrease of 4.7% across all of our rating areas. That 7% premium reduction target was also facilitated through the creation of our reinsurance program, which was done under our state's 1332 innovation waiver. The reinsurance program created under the public option program reduced premiums 4.4% across the entire individual market for plan year 2026. And this year, with open enrollment coming to a close and starting to get some preliminary data back, we're seeing that Battle-Born State Plan enrollments accounted for approximately 10% of total enrollments through Nevada HealthLink this year. And I will pass it back to Janelle.
Thank you. All right, this slide right here is just an updated graph of kind of our enrollment trends over a year-over-year comparison starting from 2022 to the end of this open enrollment, which again concluded on January 15th of this year with final plan selections through the 20th of January. So as of 1/23, we also pushed out a press release kind of letting everybody know where we landed with numbers. We are tracking 104,286 net health enrollees. And I just wanted to mention that the numbers on the far right of this graph reflect where we ended after each open enrollment period of that plan year. But the press release and this graph also includes the number of active enrollments. This was active enrollments plus our new consumers, and that was a total of 63,563. Our active re-enrollees were 42,652. And then new consumers, which is always very exciting, was 20,911. And then we saw a percent of increased active enrollments compared to last year of an increase of 32%. So really excited about those numbers, even given the rate increases and additional costs. So we're all keeping a very close eye on how the trends will look in the next few months and as we go into the spring for open enrollment as well as special enrollment period. Thank you. That concludes my remarks.
Perfect. Thank you, Janelle. All right. So next we have the Patient Protection Commission. And for those of you who may not be familiar, the Patient Protection Commission is a 12-member health policy advisory commission within the Nevada Health Authority that provides data-driven analysis and policy recommendations to improve the quality, accessibility, and affordability of healthcare in Nevada. So during this interim, the Patient Protection Commission is focusing its work on perinatal health. Our goal really is to build a shared understanding of maternal and infant health outcomes and identifying the challenges and facilitators that impact access and quality. So over the course of the Commission's meetings, we'll start by reviewing statewide data and research. And then from there, we'll hear from subject matter experts, state and national leaders, providers, and patient perspectives to better understand where the gaps exist and some opportunities for improvement. So as we move through the interim, we'll identify potential policy solutions and refine those ideas into evidence-based recommendations, including legislation and other actions ahead of the next legislative session. For those of you who want to stay informed or be involved, please be sure to sign up for the Patient Protection Commission listserv and find information on the website that are both linked here. And as a reminder, we will have a copy of the slide deck will be posted online. We'll also be prepared to send that out through our listserv and all the notifications. So you will get a copy of these slides after this workshop today. And if you have any questions, please be sure to reach out to the Patient Protection Commission inbox, which is also listed here. And Dylan Malmlove is actually the Executive Director of the Patient Protection Commission. I'm just filling in for him. He was unable to be here today and sends his regrets. So with that, I'm going to pass it off to Dr. Keiko Duncan.
Good afternoon, everybody. Dr. Keiko Duncan here. So just a couple large initiatives we wanted to make sure you all are aware of. Effective January 1st, 2026, this year, Nevada Medicaid Fee-for-Service and managed care plans moved to a unified list of preferred outpatient drugs, which we fondly refer to as the single preferred drug list. There is going to be a legacy coverage phase, which is essentially going to run for about 6 months between now and June 30th. And this is going to allow our recipients to continue their current prescriptions to help transition when appropriate to a preferred medication on that list. And just to note that the single PDL does include drugs on the Nevada Medicaid PDL, the prescription medications. It also includes some of our utilization management measures, which the public might be aware of as like prior authorizations, quantity limits and such. We are also unifying our physician administered drugs so that those are medications that are billed through a medical benefit, for example, as well as our diabetic supply list. So that's all going to be unified under the single preferred drug list. And next slide. Thank you. Our other big initiative is the single PBM implementation. So during this past legislative session in 2025, SB 389 required NVHA to implement a single state pharmacy benefit manager, also known as a PBM, no later than January 1st, 2030. The hope being that we will be controlling costs for state coverage programs and maximizing that rebate revenue for the state. An update that we have here is this, we are currently working through various Medicaid authorities that this might states prior, as well as some federal authorities. So the request for proposals is anticipated next year in 2027, with some staffing requests that will go to the Interim Finance Committee here in 2026 as permitted under legislation. And with that, I will pass it over to Nick, I believe.
Thank you, Ms. Duncan. My name is Nick Proper, and I serve as the Operations Officer for PEB. The following items have been approved at the last few board meetings on this list. Some are enhancements and some are changes to cost shares for the members. The first enhancement is we'll be implementing a UMR medical prescription coupon program. This will be only for medications administered by the medical side of the plan. We are also removing prior authorizations for biopsies, MRIs, and dialysis. And diagnostic breast imaging and colonoscopies will be covered at 100% on LD and PPO, LD, PPO, and EPO, and on CDHP after the deductible is met. Another one is the first annual out-of-network lab will be covered as in-network, and there'll be education to members that if a subsequent out-of-network one will be paid as out-of-network. For the cost share changes, we've added a deductible to the LD PPO plan of $300 and $600 for individual and family. We've raised the deductible on the CDHP to align with the IRS minimums. And we've increased the out-of-pocket maximum on the CDHP and the LD, but we've actually decreased it on the EPO plan. These are all subject to change at the February and March board meetings, where the final plan design for plan year 27 will be finalized, and that will begin on July 1st. And we're also working with the NVHA for new vendors, for actuarial needs, and just to really do a deep dive into the program for cost containment and network issues. Now I'll pass this off to Director Weeks.
Thanks, Nick. I'm going to go ahead and step in. This is
Good.
Lauren
Thanks,
Driscoll.
Laura.
Yeah, of course.
Thank you.
Lauren Driscoll, Regulatory Counsel for Nevada Health Authority, and working with the Healthcare Purchasing and Compliance Division regarding our healthcare purchasing activities. So as we all know, Senate Bill 494, Section 24 granted purchasing authority to NVHA. And as part of that purchasing authority, we are required to adopt regulations that would give us guidance and vendors guidance on our policies and procedures around competitive procurement. We do currently have a requested draft of those regulations submitted to Legislative Counsel Bureau, and we have been assigned an R number. I'll go ahead and say that R number. It's 009-26, and we can provide a link to that form that's been submitted through LCB in the chat. So we do have that draft in progress. I want to remind folks that we held a public workshop regarding the proposed summary of regulations on November 12th, 2025. We do anticipate that we'll be hosting either future workshops or hearings regarding adoption of those regulations. So once we have that draft back from LCB, we'll go ahead and have a better idea of how those public meetings will be scheduled, and we'll circulate notice appropriately for any future meetings. In addition to adopting regulations, Nevada Health Authority will be employing a comprehensive healthcare purchasing strategy in order to leverage the state's total spend on healthcare services and coverage products. And in that way, we can drive better value across markets. We have secured vendor support to work with national consultants on this strategy initiative. So I believe January BOE, we secured that vendor support, and that's an ongoing project at NVHA to come up with that comprehensive strategy. Mr. Proper had mentioned during the PEB presentation that we were looking at having that vendor support to analyze current offerings and coverage under the PEB program and provide a board report in terms of how we might be able to model some new programs or make changes to the current program to save costs. So that's something that's going on through the Healthcare Purchasing and Compliance Division in conjunction with PEB. In summary, we can announce that the goals of Nevada Health Authority in implementing its healthcare purchasing regulations and strategy would be to align requirements across markets for both vendors and providers in terms of healthcare coverage and programs, allow the state to better leverage its spending footprint to negotiate lower costs in healthcare, and also provide the agency with an opportunity to scale resources across programs. So that might apply to our day-to-day operations as well. If there's tools that can be utilized across divisions at the agency, we can leverage that purchasing authority to get the best value. And I believe I'm passing on next to Cynthia Leach, in our administrator of the Healthcare Purchasing and Compliance Division. Thank you.
Thanks, Lauren. Good afternoon. My name is Cynthia Leach, and I'm the new administrator over the Division of Healthcare Purchasing and Compliance. On this slide, I'd like to share some fraud, waste, and abuse billing trends the Surveillance and Utilization Review, or SUR team, commonly sees in the Medicaid space. Impossible billing is our top fraud referral reason and is specific to billing an excessive number of services by a servicing provider in a single day. Next, we have upcoding, which is billing services at a higher rate than what was actually provided. An example of this could be billing for a new patient visit to receive higher reimbursement when in actuality the patient was already an established patient. Inpatient conflicts have spiked on our radar recently. This includes billing services in a home or office setting while a patient is already in an inpatient setting. We've recently stood up a new data analytics platform that utilizes artificial intelligence to detect anomalies and patterns. This new tool has allowed us to quickly identify these scenarios, and as a result, we've initiated a significant number of provider payment suspensions. And last, one of our most prevalent concerns is failure to maintain adequate records to support billing. Providers are required to keep records sufficient to establish medical necessity and to fully disclose the basis for the type, extent, and level of services rendered. The Nevada Medicaid Provider Contract outlines expectations for record keeping, as well as the Medicaid Service Manual, Section 103.13. And NRS 422.570 describes actions that can be taken related to the intentional failure to maintain adequate records. Please note we are currently looking at opportunities to engage with providers and stakeholders to clearly outline policy requirements, billing expectations, and to address most common fraud, waste, and abuse concerns. In response to investigative findings, SUR can take a variety of actions depending on severity. Examples of potential actions include provider education letters, verification of service letters to recipients and servicing providers, recoupment of overpayments, corrective action plans, suspension of payments, and finally, provider contract termination and potential sanction. Included here is some data showing the number of cases opened by the top 5 provider types, as well as the top 5 reasons the SUR team refers cases to the Nevada Attorney General's Medicaid Fraud Control Unit. Next slide, please. SUR investigates every referral received regarding fraud, waste, or abuse. Cases can be generated by data analysis, projects related to national trends in collaboration with federal and state partners, and most importantly, by referrals. Anyone can submit a referral via our website or phone number listed here. The SUR team works very closely with the AG's Medicaid Fraud Control Unit, or the MFCU, and upon identification of a credible allegation of fraud, SUR will make a referral to the MFCU to determine the legal conclusion of whether fraud has occurred. And thank you. I'll pass it over to Melinda for the next slide.
Great, thanks, Cynthia. Okay, moving on to a workforce grant initiative. So there are 2 very big initiatives that have begun in the state. The first that I want to go over is the State Healthcare Access and Recruitment Program, otherwise known as SHARP, which came out of Senate Bill 5 from this most recent special session in 2025. This bill appropriated $60 million to be able to support workforce capacity and obviously sustainable results for healthcare. Basically, the funds for the SHARP program will be available after July 1st of 2026. So the state is currently working on developing the required assessment and report that's necessary to be able to develop the request for applications for folks to be able to apply for the 60 million. The state anticipates having the request for applications for the SHARP program available in the middle of July of this year. So looking to get that out as soon as possible, and we will be sure to share that on our listserv and all of the communication channels that the agency has. Next, we have the federal Rural Health Transformation Grant. This came out of HR 1 of this year, or last year, I guess. And this federal grant opportunity has awarded Nevada almost $180 million in year 1. This is a 5-year grant program. So each year the state must apply for or reapply for these funds for each year. And we have been awarded CMS had requested that states apply using a hypothetical budget of $200 million per year to do the application itself. Then CMS goes through, and basically half of that funding is baseline funding. So half of the available funding for the year is awarded to all awarded states. So all 50 states applied, all 50 states were awarded. So all 50 states got half of that baseline funding. The other half is called workload funding, and that was calculated based upon how well a state scored in different initiatives that it put forward in its application. Also included information such as rural demographics and the rural health system that the state has in place, and other initiatives that the state put forward. So with that, I'm going to turn it off to Jason Blake to walk through a little bit more details in the Rural Health Transformation Program.
Thanks, Melinda, and good afternoon. I'll introduce myself very briefly. I'm Jason Blake, and I have the privilege of serving as the agency manager over the RHT program, and feel it's a true privilege to work with such a monumental program. We have an opportunity to truly transform and improve the healthcare in our rural and frontier populations and communities. It hasn't just been Melinda and I working on this program. I do want to recognize Alicia Roman as our fiscal officer, and also Dina Schmidt as our program chief. They have been very instrumental and helpful in getting us to where we are now. Now, as Melinda explained, following the guidance and direction given by CMS, Nevada Health Authority submitted on behalf of Nevada, the state of Nevada, an approved application and was awarded a little under $180 million for the first funding year. As outlined in our application, we have 4 initiatives designed to accomplish the goals of the program. These initiatives are as follow: Rural Health Outcomes Accelerator Program, the Flex Fund to strengthen rural health infrastructure, Workforce Recruitment and Rural Access Program, and Rural Health Innovation and Technology. Now we'll go back and I'll address each one of these individually. For the Rural Health Outcomes Accelerator Program, also known as ROPE, we're a government agency. I guess we love all these acronyms, and so we're following right in line. But for the ROPE, we have allocated 15% of our budget to promote the evidence-based and outcome-driven initiatives that are brought forward, focusing in chronic disease prevention and management, behavioral health, prenatal care, just to mention a few. I know that in each individual area of the state, rural area of the state, there are different problems and different initiatives that need to come forward. These need to be evidence-based and outcome-driven initiatives to improve the healthcare. Now, these monies will be driven through an RFP process, and we'll talk about the RFP and the RFA process and timelines a little bit later. Our next initiative is the Flex Fund to strengthen rural health infrastructure. This has 20% of the budget is allocated in this area, and is to address rural critical access hospitals and clinic infrastructure needs. We hope that those applying for these funds will leverage regional buying powers and strategies. And we hope to see some collaboration throughout the state to share resources in these efforts. Unfortunately, there can be no new construction. Now, we do believe that there are opportunities to use some of this money to enhance service areas, maybe to do some remodeling as you improve and as you add new service lines. But there cannot be any new construction. And these monies will be directed through an RFA process. Our next initiative is Workforce Recruitment and Rural Access Program. We've allocated 40%. This is the largest amount of money allocated in this area to this initiative because we feel it's so important. We feel this is a way to truly benefit rural healthcare for years to come. We hope that this money, and we seek proposals and applications to grow your own pipeline of employees and of qualified professionals, to recruit and train various healthcare professionals throughout the healthcare delivery system. We hope that they'll address burnout, isolation, and retention. We hope to see incentives for new providers in the rural areas. And also we're excited and hoping to find ways that we can stand up rural residency programs in the rural and frontier locations. Now, this will be handled through RFP and RFAs to direct this money. And our last initiative is Rural Health Innovation and Technology. This represents 15% of our program, and it's to address and improve our digital health ecosystem in rural Nevada, improve our telehealth infrastructure, offer improved access to patient-centered care. And we hope that we can find a way that we can do all this is in an interoperable data sharing system. And again, RFPs will direct the movement of those monies. Now, for those that were adding up those percentages, it didn't add up to 100. There are a couple special allocations of these funds for specific health initiatives, and we've allocated 4.5% for tribal health initiatives and 2.65% for Nevada Division of Veteran Services and Correction health initiatives. Before I move on to the next slide, I just want to point out a few critical points with this money in this program. Is first that all projects and initiatives must align with the federal and state objectives and requirements. Next is that the benefit of these programs must be in the rural and frontier communities of our state. The projects and initiatives must be sustainable. And those that are submitting these requests and performing these projects must commit to quarterly and annual reporting processes. We will be looking for quantitative as well as qualitative reporting. All right, I'll move on to the next slide. Some of our current and next steps that we are addressing are first, we need to hire some program staff. We're currently seeking 10 state employees and 2 contracted employees to help move this project along. As well, at the same time, we are seeking to assemble a steering committee consisted of 15 committee members that will give guidance and monitoring to us as we move through this 5-year project. We're looking at having our first steering committee meeting in March, and we're looking forward to that group of people getting together. Next, we are preparing for quarterly and annual reporting systems. We're also looking to implement state policy actions. The part that I've been asked the most about is the next two little pieces about RFAs and RFPs. First, we'll address the RFAs that are going to be directing the tribal money, the veterans and corrections money, and the flex fund. We intend and we are planning to have the RFA for these projects to come out in March and be accepting applications through August 30th of 2026. So that will be an open window for those months after the RFA comes out. Next, we are looking to onboard and for assistance with we're hoping to bring on some vendors to assist us with the RFA and RFP processes for the other initiatives. For the RFAs, we expect to have these published in May and awards in July of 2026. For the RFPs, we intend to have them published in May of 2026 and awarded by September of 2026. And the contracts will run from September 15, 2026 through September 30, 2027. One piece to understand in all of this is we as the state, we are responsible to obligate this money by October 1st, all of this money by October 1st of 2026. And those that will be utilizing the money in these initiatives must have it spent and accounted for by September 30 of 2027. This first year of funding is a shorter year as we're trying to stand this project up. And so those projects coming forward, we hope that there is great planning and decision making already being made so that we can accomplish the tasks within this first shortened year. I hope that there's some low-hanging fruit out there that we can see some early wins, some great improvement and big results within this first year. Now, in closing, I want to reiterate over on the slide underneath the picture, the deadline. All year one RHT funds must be spent by September 30th of 2027. And so consider the funding timelines when developing RHT projects and activities for year one RFAs and RFPs. I'm sure there's a lot of questions. I hope there's some time at the end that we can answer some of them. If not, there's some links available. There's our website that we are trying to post updated information to. We also utilize the NVHA listserv. And then we also have our separate email address there so that we can answer questions that way. And Melinda, I think I've covered all the information. I hope to answer questions later.
Wonderful. Thank you, Jason. Appreciate it. All right, we will move on to the Graduate Medical Education Advisory Committee. So just wanted to give you all an update about those grants that are available as well. So those of you familiar, Senate Bill 494 transferred the Graduate Medical Education Program, including the Advisory Council, to the Nevada Health Authority. We were blessed with new funds to be able to support the graduate medical education program in Nevada. So we do have, over 15 million available for this next funding round. We have hired a vendor to support us in, facilitating the advisory council meetings and, getting together the requests for applications that will support this process for graduate medical education. We're really excited. We're about to meet for the third time this year with the GME Advisory Council actually this week. So Thursday is the third meeting of the GME Advisory Council since the transfer to Nevada Health Authority. And at that meeting, we hope to be able to finalize the request for application itself, as well as the scoring matrix or rubric that the council members will be utilizing to score and evaluate these applications. We are anticipating getting the request for applications posted in, oh my gosh, I'm going to say, it's very soon. So February or March, if memory serves me correctly. But basically the end goal is that we want all of these subawards executed no later than June 30th of 2026. So we're on that tight timeline to get things moving and really excited to see, what comes out of this new grant award process. So with that, I'm going to pass it off to, I think it's Cynthia, to talk about centralized credentialing. And I apologize if I got the wrong person. Yes, Cynthia, yay.
All right, Melinda, thank you. All right, so centralized credentialing was fully implemented this past year. The project streamlined the provider credentialing process by transitioning responsibility from each managed care entity to a credentialing verification organization, or CVO, allowing credentialing activities to be completed by a single entity. Our CVO completed more than 22,000 applications in calendar year 25 and is consistently meeting key performance indicators. The average time to disposition a facility application is roughly 46 days, and for a practitioner application, 19 days. We are currently aligning recredentialing dates so that one recredentialing decision will occur and be valid across all plans. And last, we are exploring other opportunities to expand centralized credentialing to other coverage programs under NVHA to reduce provider burden. Next slide, please. The NVHA launched the new Provider Flex system for enrollment this past summer. A variety of improvements were made, including a provider dashboard, error identification, and an intuitive attachment process. And from a program integrity perspective, an important feature is the addition of DocuSign. DocuSign integration enables live provider identity verification, including driver's license scanning and facial recognition video capture. As part of the new Provider Flex process, people designated to sign the provider contract are required to go through the liveness facial scan and also provide a scan of the government-issued ID prior to signing. An envelope is created by DocuSign and sent to the signer's email address. Please note the signing of required documents cannot be delegated. Providers, owners, and board members have 30 days from the date the envelope is sent to sign and return. Otherwise, the envelope expires. So please, for those of you that engage in the contracting process with Nevada Medicaid, let your providers, owners, and board members know to expect the DocuSign email and what its purpose is. Thank you. And I will be passing it over to Vanessa, I think, for the next slide.
Hello, everyone. My name is Vanessa Ramey. I'm the Portfolio and Project Management Office Manager. We're really excited about this project, and we are pleased to share the following update. With the governor's recommended budget bill passed, we are paving the way for one-stop eligibility solution featuring a real-time enrollment and managed care plan selection. Phase 1 launched December 2025, where it will introduce Magi family group determinations. And then Phase 2 will position the exchange platform as a system of record for full Magi integration within the exchange system, with a target implementation date of April of 2028. Next slide, please. So today, about 90% of Medicaid enrollees qualify under Magi, and our goal with this project is to make applying for Medicaid benefits faster and easier to navigate. Nevadans will be able to apply for Medicaid through Nevada Health Link, receive same-day eligibility determinations, And if not eligible for Medicaid, shop for qualified health plan, a health plan, and it also includes battle-born state plans, all in one place for a true one-stop shop experience. Non-Magi populations, which include the Medicaid for aged, blind, and disabled, will continue using the current process through the Division of Social Services. And that concludes my portion. I'll go ahead and hand it over to, I believe, Dr. Duncan.
Hi, everybody. Dr. Duncan here again. Just wanted to touch on the Medicaid academic partnership that we have going on right now. We have a collaboration with public universities in Nevada, hoping to enhance policy analysis, program development, and evaluation of benefits and programs at the Nevada Health Authority. Currently, we're in this phase one, you see here on the right, essentially a pilot with our University of Nevada, Reno Medical School. 4 physicians were approved through this contract and 2 have been hired as of today. We have a family medicine and OB-GYN as well as a clinical informaticist. Currently, some major projects, you've heard from the team today and our physicians have been integrated into. So some of them being value-based payment design, maternal infant health, our patient protection commission, our clinical informaticist is our health information technology consultant within that program, as well as data management measures with the Rural Health Transformation Project. Phase 2 of this will be hopefully to expand to additional medical schools as well as other healthcare professionals like APRNs and PAs and pharmacists and such. I will pass it on, I believe, to Allison. Thank you.
Thank you, Dr. Duncan. Good afternoon, everyone. My name is Allison Janko-Herzik, and I am the Chief of Staff for the Nevada Health Authority. As Director Weeks mentioned earlier, the Nevada Health Authority is focusing on developing a population health management strategy. This strategy will use data analytics to help us understand current healthcare needs and predict what people need in future health systems, including health-related social needs. We know that we can't do this work alone, so we're working closely with the UNR School of Public Health to leverage our data sharing resources and expertise to then develop the population health strategy for Medicaid, the Public Employees Benefits Plan, and potentially qualified health plans and battle-born state plans on the marketplace for those consumers. This effort requires future use of the all-payer claims database when it becomes available, and I am leading this effort alongside the Chief Biostatistician, Madison Lopi. Next slide. Next, we want to give you a quick update on the future of the all-payer claims database. The all-payer claims database is now live, but data is not anticipated to be available until fall of this year. We will be soliciting applications for the APCD Advisory Committee, so please keep an eye out for those on the NVHA listserv once they are sent. The committee will also be established in 2026. And questions regarding the all-payer claims database submission training and more can be sent to nv-support@onpointhealthdata.org. Next slide, please. And we just want to give you all a quick update on all the legislation or all of the bills that impact more than one division. So we have 83 bills that are being implemented across the health authority. So 34 for the Division of Nevada Medicaid. We have 23 for the Division of Purchasing and Compliance, 12 for the Division of Public Employee Benefits Plan, and then 4 that are being implemented through the Division of Consumer Health Services. So we're very busy still implementing bills from the 2025 session, and we are working on developing our strategy for the 2027 session as well. Next slide. And then as of October 2025, the status of our bill implementation, 28 are 90 to 100% complete, 9 are 89 to 70% complete, 7 are 69 to 50% complete, and 39 are less than 50% complete, but many due to federal approval or delayed effective dates in statute. And then federal approvals required for 12 bills, including 11 state plan amendments and 2 Medicaid waivers. That concludes my remarks, and I'll pass it back over to Administrator Jensen and her team.
Thank you all. Excited to pass it over to Sarah Dearborn.
Good afternoon. My name is Sarah Dearborn. I'm the chief over our medical, dental, and behavioral health benefits coverage. Our behavioral health team is making significant headway with several behavioral health related bills that passed during last session. 2 initiatives have been fully implemented with 4 new behavioral health service model benefits already under review with our federal partners at CMS, working their way towards approval. The last 2 on this list here are not far behind, with target dates for submission to CMS in the near future. Each of these bills contribute to stable programming and innovative ways to increase access to behavioral health care for unique populations. I will pass it over to Yvette for the next slide.
Good afternoon, everyone. My name is Yvette Cullen, and I am the Chief of Medical and Dental Benefits Coverage here at Nevada Medicaid. I have several bills on this page I'd like to discuss with you. AB 284 is us implementing the vagus nerve stimulator device codes, and it's really taking that out of the procedure that already exists in our services. The SPA was approved, and we are working on our system updates with a retroactive effective date for claims back to 10/1/25. AB 169 is requiring health insurance plans to cover certain speech language services with no prior authorization or service limitations up to 26 years of age. We have updated our medical services manual and our systems, and that is completely implemented. AB 176 prohibits the state from implementing limitations that burden contraception and family planning services. There were no changes needed to policy or systems, as there were no prior authorizations or limitations required on those services. So that's completed. AB 360 mandated rapid or point of care syphilis tests for pregnant women, and our manual has been updated. That is implemented completely. SB 344 requires coverage for non-invasive prenatal testing for chromosomal abnormalities. Our manual was updated, and that is completely implemented as well. E267 was mentioned earlier by Dr. Benson. That is adding adult dental coverage, and we are pending our initial SPA submission. That will be implemented, like he said, July 1st, and we should be on time with that. AB 428 is preserving fertility for women diagnosed with ovarian or breast cancer. We are working on the 1115 waiver proposal, and we will get that submitted as soon as we can. And I'm going to pass it over to Jeremy Hayes.
Excellent. Thank you so much. My name is Jeremy Hayes. I'm the Chief of Rates for Nevada Medicaid. I know that it looks like I've got a much smaller list than our behavioral health and our medical and dental benefits, but rest assured, my team touches most of those. I'm just going over the very rate specific ones. Taking a look at my list here, I've got 2 budget items that are completely implemented. One is a rate increase for partial hospitalization, and the other is a rate increase for day treatment services. I do have a bill and a budget item that are still pending initial SPA submission. The first of those is the ambulance rate increase that is related to the new provider tax. Notably, this was submitted immediately previous to the federal reconciliation bill, which prohibited additional provider taxes. So we kind of got that one in right under the wire. But we're still working with, getting that fully set up. And then the other budget item that I have that's pending initial SPA submission, state plan amendment submission, is our mobile crisis rate reform. NVHA is working with an outside contractor to rebuild how these rates were developed in an effort to make access to this care more prevalent. Thank you very much for your time. I believe I'm passing the presentation off to Tanya Stevens.
Hi, everyone. I'm Tanya Stevens. I'm the agency manager for Medicaid Eligibility and Enrollment Policy, or E&E. We oversee the development, implementation, and maintenance of policies that govern how individuals qualify and enroll in Medicaid programs in collaboration with other units and agencies. We're responsible for ensuring compliance with federal and state regulations, guiding, supporting strategic initiatives to improve access and efficiency, and collaborating with stakeholders to align policy with program goals. We strive to streamline eligibility processes and support equitable access to healthcare. As you can see here, we have 2 bills from the 83rd session that we are actively working to implement, both of which help improve access to care by streamlining access to presumptive eligibility. Presumptive eligibility is a provision that allows certain qualified entities to determine that an individual is likely eligible for Medicaid or CHIP based on preliminary information. This helps ensure immediate access to healthcare services without waiting for a full application to be processed. These bills are both actively in progress, both involving state plan amendments, and include Senate Bill 138, which increases the opportunity and avenues for pregnant women to apply for healthcare services through the presumptive eligibility process, and SB 312, which increases the opportunity for Indian tribes to determine individuals' presumptive eligibility for temporary Medicaid coverage. Please feel free to reach out to me, and I'll also be available at the end of the call if there's any questions and time to address. Thank you. And I am passing it on to Kirsten.
Hi, sorry, I froze there for a second. Yeah, thank you so much, Tanya, Kirsten again. So we already touched up on PACE and our BCCP program earlier on. So the other bill that we are looking at implementing for our community supports services is our personal care services for children. And so we right now are working through some technical assistance with CMS. They offered us that opportunity to be able to work through what type of home and community-based authority really will be the best fit for this particular service for children. And so we will be starting that in the coming weeks. And then once we have that technical assistance from CMS, Centers for Medicare and Medicaid Services, our federal partners, that'll really then allow us to have that guidance on which path we take. And then we'll be able to start drafting those updates to either a 1915C waiver or 1915I state plan amendment, and we'll certainly be holding public workshops for that once we have a better idea of which authority makes sense. And so that's the updates I have, and I will be passing it over to Paul.
Hi, everyone. I'm Paul Schubert, Chief of the Bureau of Healthcare Quality and Compliance. HCQC tends to have touch points with a large number of bills each session. And so several of them have actually already been listed previously. So I'll focus on the bills we're still working on. So if I could go to the next slide, actually. So AB 484, this is a data collection bill. And we're just working with DHS to establish a connection to their link. And once that is done, then we'll actually provide the data necessary for publishing that information. And then AB 514 is licensure of a new provider type, rehabilitative residential mental health care facilities. These are very similar to psychiatric residential treatment facilities. We've already drafted the regulations, and they have an R number, that's R116-25. And we've already done sent out information to obtain small business impact. And as soon as we collect that information, we'll start our public workshops. Let's see. So, I'm sorry, AB 519. They haven't actually codified the statutes yet, so we don't know which chapter these new statutes will fall under. But we have contacted our colleagues in the FBI with regards to the language in the bill, and it appears that we're not going to be able to do background checks unless we change the language. So we've already drafted a BDR for next session to modify the language so that it will be acceptable to the FBI. So let's go to the next slide, please. So AB 544, this is an agency bill that just updates when we actually renew licenses or when licenses expire. Right now, for most all of our healthcare facilities, the license expires on December 31st of each year. We wanted to spread that out So this bill changes the language so that licenses will expire upon the anniversary date, so that when a healthcare facility is initially licensed, the license will expire 1 year later. And if we could go to the next slide. Okay, SB 299 is our Senior Living Community Referral Center regulations. And we actually had a bill in the 2023 session that we developed regulations for. This bill modified that language. And so we're working through the process to get the language worked out between the two bills. And we will be actually continuing with that regulation process for the R number for that set of regulations. It's R081-24. So once we fix the language, if you will, we will continue that process. And I believe I'm turning it over to Nicholas Proper or Teresa Karsten.
Thank you, Nick Proper again, Operations Officer at PEB. So for our first two bills, these were effective this month, and they were complete as no changes or revisions were required, as we've already been in compliance with AB 176 and SB 246. For the next two, SB 344 that provides coverage of non-invasive prenatal screening, this was taken to a board 2 months ago, and we approved it, or the PEB board approved it, and we'll just be updating our master plan documents effective July 1st, 2026. For AB 428, this provides coverage for preservation of fertility, and we also took this to our board, PEB board approved, and we will be updating our master plan documents effective July 1st, 2027 for this bill. Now I'll pass this off to Adam or Janelle.
Hello, this is Joseph Filippi, actually serve as a policy analyst from the Silver State Health Insurance Exchange. I'm going to give a quick update related to our Divisions 3 bills that we're working to implement. For SB 97 and SB 494 from the 2025 regular session, both of those bills revise the composition and governance structure of the Exchange Board. The board is now composed of 7 voting members and 1 ex officio non-voting member, and all members serve in an advisory capacity for the Silver State Health Insurance Exchange. The advisory board recently met last month on December 22nd, in which they approved the exchange's semi-annual fiscal and operations report, which was later submitted both to the governor and the legislature. And then for those interested, the next board meeting is scheduled to occur next month on February 24th at 1:30 p.m. For more information related to the advisory board or the exchange, please visit nevadahealthlink.com. And then moving on to SB4 from the special session late last year, both Section 10 and Section 11 are currently being implemented by the division. We are finalizing the details to distribute broker payments who assist with consumer enrollment with battle-born state plans. So that those are being processed shortly, hopefully. And then related to Section 11 of the bill, that section established a grant funding program for navigator agencies who provide enrollment assistance for Nevada Medicaid and battle-born state plans. The division is contracted with a vendor, HMA, who is helping us to implement the community-based navigator grant program, and also assisting with helping us develop a cost allocation plan to draw down additional federal matching funds. So we are currently planning to release the request for applications for that grant program later this spring. So keep your eyes peeled for that through our listserv. And I'm now going to pass this over to Monica Schiffer.
You're on mute. Thank you, Melinda. Sorry about that. Thank you, Joseph. This is Monica Schiffer with the Nevada Health Authority's Director's Office. And I wanted to talk about some stakeholder engagement opportunities coming up. As Director Weeks mentioned earlier in this presentation, one of the pieces of the strategic priorities is to include more stakeholdering, community and provider engagement opportunities throughout the state. And so I wanted to go over a couple of things coming up. We have the Public Employees Benefit Program Board meeting on February 18th. As Joseph just mentioned, we've got the Silver State Health Insurance Exchange Board meeting on the 24th. We are planning a rural hospital tour in the spring. Probably March is when we're going to start going out. That will run March through approximately May. March 3rd will be our Medicaid Advisory Committee and Beneficiary Advisory Council meetings. March 11th is a statewide healthcare access and recruitment program, the SHARP program that Deputy Director Southern spoke about earlier. And then the inaugural Rural Health Transformation Steering Committee meeting is March 11th. And I know there is a lot of interest in that program. Some of the other opportunities that we have going on, school health services that Erica McAllister spoke about earlier. We have a steering committee coming up. Children's Behavioral Health Transformation Group has monthly working group meetings. And then the Reentry Initiative also has technical assistance sessions. And I don't think they have one scheduled right now, but all of this information can be found at nvha.nv.gov or by reaching out to the provider engagement email address. We also participate in tribal consultation and ad hoc meetings for the Nevada tribes. We have a quarterly hospital consortia and bi-monthly rural hospital partner meeting. We meet with the FQHCs quarterly, the National Alliance on Mental Illness. We meet with those chapters quarterly, and the Nevada Association of Counties quarterly. Again, just in an effort to make sure that we're getting messaging out, reaching out to all of our stakeholders. If there's ever any information that you folks need or would like from the department, please feel free to reach out to us. And I am going to turn it over to Catherine Nielsen.
All right. Apologize. All right, thank you guys so much. My name is Catherine Nielsen. I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. My piece will be super short today. We're coming to talk to you guys about our Silver State Self-Advocacy Conference that's taking place in August of 2026. This is our biennial conference that takes place on the opposite ends of the state. So this year is going to take place in Las Vegas. Our hotel is going to be announced hopefully next week. Registration is open, and it is available for proposals for speakers, any breakout sessions that you might have in mind, and general sessions. And we're also looking for our keynote speaker. The last piece is that it is for self-advocates or individuals with disabilities, their family members, and we do have a limited number of spots for professionals in the disability community that might need a little bit more time with us and training and learning on how to serve the disability community. And it's open for any stakeholders to attend and apply. It is free for attendance. So if you are a stakeholder in one of those three categories, we highly encourage you and we would love to see you there. It is a 2-day conference. You can see our conference website at the bottom of this page. But if you don't have access to this right now, you can also go to our nevadaddcouncil.org website and find a link right there. I will give it back to you guys for questions. Thank you.
Wonderful. Thank you, Catherine. All right. We have made it to the end of our slide deck. Oh my goodness. All right. So now comes the time for questions. So we're happy to answer questions from the audience if you guys have any. So please feel free to use the raise hand feature in Teams, and we'll begin calling on folks. So let's see if I can get my thing to come up. Okay. So we will start with Matt. Matt, you have your hand raised. Please go ahead.
Hello, can you hear me okay?
Yes, we can. Thank you.
Yes. First, I want to express my gratitude to the Nevada Health Authority. Such a tight deadline that you were working on to submit the RHT application. My question is about the application, specifically section B3, which presents the proposed SNAP food restriction waiver. Given that many rural Nevadans live in food deserts, where retailers like Dollar General can be a primary food source, could you clarify what evidence, data, or community input informed that proposal?
Sure. I'm going to
So-
pass that off to our director.
Thank you. So thank you for that question, Matt. We are just reporting out on the state agency that oversees that and their work on that. So we would not be able to speak to that. We're just putting in our application the actions that are being taken at the Division of Social Services and the Department of Human Services that oversees that program. So I unfortunately cannot answer that question. That is not our decision.
Thank you for
But
that.
we can send you, I mean, if you want to reach out to Administrator Robert Thompson, he oversees that program.
Yes, I would love to have some
Okay.
follow-ups too. Thank you.
Okay. Mhm.
Thank you. Next on our list, I see Senator Titus. Please go ahead.
Hey, thanks everybody. What a thorough presentation. At one point I saw that there was 419 people signed up to this. So your outreach was pretty tremendous and very informative. Two very specific questions. First, noticing, and thank you for that $1.8 million looking at the residency programs, and I'm wondering how you plan on actually using towards some of that, because as you have already stated, we have to spend it by 12/27, and as you well know, the programs can take up to years to get started and become somewhat sustainable. So we already have, I think, about $15 million in the funding, and I'm glad to see the GME Council is having their meetings. But what was the intent with that specific amount going to the residency programs with a limitation on timeline?
Melinda, I'll take this one. Thank you, Senator. That's a great question. We definitely grappled with that. So part of the issue, what we were thinking there is that we fund the first, so we have a bucket of funding and it's not just all going to the residency. The goal is to put some of that into some of the other incentives, including bonuses, housing, other incentives to get folks to move out. So that's kind of like the immediate tackling on the ground of the issue. And then over the 5 years, we have 5 years of funding. So we're going to continue to apply for this bucket. So the goal is for that first year, if folks apply and get the award, that are doing a rural residency program, this would be additional funding to support that work or to build that out over the 5 years. But it would not be the only thing we'd be funding with this money. I'm totally recognizing that. Yeah.
Yeah, it takes a while, and then that's one of the things that we did last session was make sure we could roll over that funding in GME, but this kind of money is not what we could do with that. So thank you for that. And one quick question. Nobody mentioned hospice. What's up, you guys? Where's that hospice program and funding? Where's that fall?
Oh, and
you're
they
rolling
can apply.
Your eyes.
Yeah, no, did I roll? I did not mean to. I hope I didn't. I know it's your favorite topic. No, they can definitely apply for the funding under any of these buckets. We're going to be working with rural communities to find out. We don't want to assume that we know what people need in these communities. It's our job to work with them to ensure that applications and that the people that are applying need to work with those communities. Say, we worked with this community and the community said they need this and we can provide that service. So that's what we're looking for. So hospice is definitely not out of the box. It's just, I think we weren't being specific to the various needs that happen in the rural communities. So Melinda, correct me if I'm wrong on that. Is that right? Okay.
Spot on.
Okay.
Real quick, and I appreciate that. Just wondering, is there some process where we could do a study on really what is the access and where the voids are in hospice in the state of Nevada, and which department would that be under if we were to look at maybe getting something started? Really, what hospice do we have here? Where do they go? And I know, as I've spoken to you about in the past, that there are true voids. And how do we get that started?
So I think we have a lot of resources already at DBPH as well as Dr. Packham at UNR. I think what our job under SB 5, which was passed during special session, is to look at all those resources and start to look at those gaps. So I think we are going to take that on, given that we're supposed to pull all those resources together and come up with a list, not only for SB 5, but I want to leverage that in our team, Melinda, and our Office of Analytics with Allison, to really look at a continuum of care and what we think should be in the rural communities and what is missing in terms of the basic care continuum. So I think that's going to be the question too, and we need a workshop. What do we think the care continuum should be in a rural area. We can't have everything, right? But what are those basic things and what is missing in each of our regions? So some of the stuff, lucky for us, a lot of that work I think has been done. I think it's just taking those resources together and laying it out to see what is missing in each of the regions by county.
Great.
But we'll take it on. If that answers your question, Senator, we will take it on with our colleagues.
Well, it gives me a good direction, though, and thank you very much for that. And I think at first doing that assessment on what specific needs are unique to each state county and statewide, even in the urban areas, I really look forward to that. But making sure that hospice is one of those questions.
Okay, you got it.
Great.
Thank
you.
Yeah, good to see you.
Thank you. Okay, so any other questions, please feel free to raise your hand in Teams, or if you're calling in, go ahead and just come off of mute and we can try and answer those as they come in. Just looking, we've got somebody in the chat. Okay, so Marina, please go ahead.
Hi there. I have a question about what the restrictions are on the rural residency. Currently, our hospital operates in Las Vegas and in Henderson, but we do have a program that supports GME residents in rural communities such as Mesquite. So I just wanted to see like what the parameters are around that.
Yeah, thanks for the question. So for that, we are onboarding a vendor to help us walk through a lot of those design questions when we're looking at the way that we want to design the RFP and the RFAs to support those projects. So we haven't, fully perfected that guidance yet, but I would say that is definitely on the table. All those collaborations is really what we are encouraging. We want to encourage partnerships between, communities, between counties, between different ways to bring healthcare to rural Nevada in different innovative ways. So definitely open to that, Marina.
Thank you.
Sure. All right, we've got another hand raised. Tara, please go ahead.
Hi, yes, Tara with Mom's Meals. We were just wondering if you had any guidance on the ILOS program and when guidelines might be available for us. Thank you.
I'm Melinda. I'm happy to take that one.
Thank you,
Or
Anne.
Stacey-
No,
Yeah,
I was looking for you or Jamie. Thank you.
No problem. So Tara, nice to meet you. Our ILOS program, our policy is in the final stages to be published publicly, but our managed care entities are rolling this out on their own time as well in accordance with our contract requirements. So I would recommend reaching out to your MCO partners that you've worked with in the past, or if you have trouble getting a hold of anyone or want to talk to someone, please don't hesitate to reach out to that managed care email address that's been in the chat. We can drop that in again right here. We're happy to connect you there, but that will be your best resource to answer specific questions, and the broader state guidance on that policy will be going out very soon as well. So I hope that's helpful, and we'll drop that email in the chat there.
Thank you, Anne. Appreciate it.
Great, thank you. Let's see, we've got Josh. Please go ahead.
Hi, thank you. One of the common themes across many RHTP applications is the need to spread specialized care out to rural America. And I'm wondering for those needs in Nevada, whatever those clinical needs are, if you've already designated the clinical experts that might be in Las Vegas or Reno that you may need to consult with on how best to extend their specialized care out to the rural communities that need them.
Yeah, thanks, Josh. We definitely have been working with folks all across the state, on developing our application, as well as moving forward. We are assembling the steering committee, which includes a wide variety of folks to help to guide this work. And so, definitely open to talking with whoever we need to ensure that we have, those partnerships and that we put forward the best program that we can for Nevada. Let's see, I'm just going to check the chat here really quick. I don't see any other hands raised. Let's see. Oh, Dr. Ryan, if you want to go ahead, please. Dr. Ryan, you've got your hand raised, but I don't see you coming off mute. Maybe we are having technical difficulties. I'm not sure. If you want to, oh, there you are.
I'm off mute now. Sorry.
Yes.
Where do emergency medical services fit in the buckets that you were talking about for the health authority reorganization?
I'm sorry, what was the first part of your question? It broke up a little bit.
Oh, sorry. Where do emergency medical services fit in the reorganization of the health authority?
It is, this is Stacy. It is actually still under DBPH, under, it's now Administrator Andrea. I'm going blank this right now for names right now. I'm a little tired, but no, it's under Andrea's team. We can send you a link to that website, but it's still the same. It's not Andrea Rivers. It's not under NVHA.
I see. Thank you.
Sure. And then we've got Elko County. Please go ahead.
Hi, this is Delmo Andriozzi. I'm a county commissioner here in Elko. How are you?
Doing well, thank you.
Great. Hey, thanks for coordinating this. I just wanted to just a couple of quick thoughts for you. There was a lot of information in this. For me, and maybe I'm not the appropriate person to participate with this meeting, but it felt like I was drinking from a fire hose. So I don't think I'll need any water to drink for several months, but there was just a lot of information to unpack there. And really, I was kind of really hoping to get a little bit more information on the RHT program. And my comment is that, and we touched on it here and there a little bit, but I do think that it's important for us to focus on a coordinated effort. Collectively, that's what I'm trying to do here in Elko County, of working with our stakeholders so that we have, we've got just one chance to spend this money, and we want to be effective and have an impact, that really truly transforms the landscape that we live in today. So, I'm really looking forward to the way this rolls out in the future. And again, the other stuff was just so comprehensive and just a little bit over my head. I'm going to have to absorb that for the next while.
This is Stacy. There are a lot of people that come to us and need a lot of information. We're a very large organization that serves a lot of people. So we were trying to be comprehensive because it's the one time we actually are providing full updates. We started doing this when we were just Medicaid for legislative. The Rural Health Transformation Grant is one thing that we do at NVHA. We will be having specific meetings on it. Melinda's going to be having her own workshops just on that topic. So I apologize that it wasn't up to what you were expecting, but we are trying to meet the needs of multiple stakeholders that come to our agency for services. So thank you.
No, that's a great explanation. I appreciate that. I just, that wasn't overly clear to me when I signed up. So thanks.
Thank you. Appreciate the feedback. All right. Any other questions from folks? Grace, yeah, you have your hand raised. Go ahead.
Oh, hi, thank you. Just a quick question with the RHT program. Potentially under that rope bucket, I was glad to hear Senator Titus bring up hospice. I'm curious if, and maybe this is something I need to look deeper into outside of today's meeting, but just in case it's offhand, would funding between palliative care, hospice, as well as pediatric palliative care and hospice be all under the same bucket? Or are those parsed out?
Great questions, Grace. So we haven't developed that guidance fully yet. So we'll be sure to, be very clear in everything that we release for each of these initiatives and what exactly they would include, and maybe give examples of some different, stakeholders and agencies that they could include in those partnerships. So willing to work with you on that if you'd like. I know that you're already engaged with Monica's team, and so happy to incorporate that. Thank you.
Thank you, Melinda.
Any other questions from folks? Okay, well, with that, I think we can go ahead and conclude our meeting for today. It's been a long one, but a lot of good information shared. We will be posting the slide deck as well as a link to the meeting recording on our website, as well as sending it out through the listserv and our various communication channels. So just want to take a moment to thank you all so much for participating today, and hope you all have a great rest of your day. Thank you so much.
Thank you.